Well, thank you, Corey. I'm really pleased to present the next topic, which is titled Positioning Current and Emerging Anti-Cytokines and Anti-Integrants in IBD Management. We can think a bit more about some of our existing biological therapies and where we might position them and compare them to each other. I do have some disclosures that are important to know, although this presentation is entirely my own and I take responsibility for it. I've put together a table that includes the different classes and targets of therapies across immune-mediated diseases, not just inflammatory bowel disease, but as you can see across the top header row, it includes rheumatoid arthritis, spondyloarthritis, psoriatic arthritis, and psoriasis. And you can appreciate that there's an overlap for some of our therapies in these other areas. And one of the themes of choosing therapies in inflammatory bowel disease at this conference, and for sure in my presentation, is understanding when comorbid illnesses help you choose one therapy over another. I want to make a couple of specific points with this table, however. The first is that our alpha-4 beta-7 integrin inhibitor, which is Eustachia, by nature of its design and its target, is selective just to the bowel and therefore does not work and hasn't been specifically studied even in other areas outside of Crohn's disease and ulcerative colitis. The second point I want to make is that the S1P1 receptor modulator therapies similarly are thought to work predominantly on the activated lymphocytes in the lymph nodes of the gut and are not otherwise expected or known to work in other conditions. And lastly, I want to point out to you that the IL-17 inhibitor seems to have actually made Crohn's disease worse in some patients or even brought on de novo Crohn's. Although larger data sets bring this into question, it seems like a relative contraindication. So while it works in other conditions, as you can see across the row, it doesn't seem to be an appropriate therapy to consider for IBD. So when we look across all these treatments, you can appreciate that either a therapy works in multiple diseases because of its broad activity, or it may work specifically or selectively in the gut. And you can imagine, therefore, some different safety profiles related to these as well. Now, when we get to our IBD therapies, of course, we can divide them into three major classes, what I've called the immune modification or immune suppression class of therapies that are all listed there, the microbiota manipulation class of therapies, which, although the data are not as rich, is certainly of great interest, whether it's dietary treatments, antibiotics, prebiotics, probiotics, or even the fecal transplant, which we now are calling intestinal microbiota transfer, or more recently, bacterial-derived proteins. And of course, surgery, whether it's resection of fibrostenotic or management of complications of the disease, or resection because of lack of response to medical therapies. Now, focusing further in on the inflammatory bowel disease patients, our biological therapies and our novel targeted synthetic JAK inhibitor, tofacitinib, are all approved and have been mostly studied in the moderate to severe IBD populations. You can see in this table the difference between the induction phase of treatments and the maintenance phase of treatments, and specifically, of course, the different indications. Most of the therapies have been studied and can be used in Crohn's and UC with a couple of important exceptions. Methotrexate now has randomized placebo-controlled trials for both induction and maintenance, demonstrating it does not work in ulcerative colitis. And similarly, tofacitinib was studied in Crohn's disease and didn't demonstrate efficacy. The final column on this table shows you other indications where you can appreciate where the drug may also be working. And this is relevant because as we start thinking about how to choose one therapy over another, knowing whether the patient has a history of these other conditions or maybe even develops them as a consequence of a therapy they're already on, you can appreciate how to select specific classes of therapies. So which treatment would you use first? We don't really know that yet. Unfortunately, we don't have therapeutic biomarkers. There are some different disease and patient issues. As I've mentioned, comorbid diseases or even extraintestinal manifestations may inform decisions. Understanding the difference between how sick the patient is right now versus their severity or prognosis is quite important in choosing your therapies. And of course, balancing efficacy and safety, as well as availability and cost, factor into how we make these decisions. And arguably, I'm sure many would say that the coverage by insurance is the primary determining factor of which therapy we might use first, but shouldn't always be. And lastly, remember that your first drug tends to work best. In many of the clinical trials, we've seen that, and I'll drive that point home in a few minutes. We've also talked, and we will be talking more about a treat to target strategy in IBD. This was borrowed from hypertension, diabetes, asthma, and of course, rheumatoid arthritis, in which we choose a therapy, that's number one, initial treatment. We arrange in some pre-specified time to reassess how the therapy is doing and whether or not we're achieving the target of our management goal. The targets for our management goals vary, and we'll cover that in just 1 minute. But if we haven't achieved the target, we adjust our therapy and we keep reassessing with predefined time intervals. This might be 4 to 6 to 8 weeks after we start therapy, or once patients achieve their target, we also keep going by monitoring them to make sure they don't lose control. That's, of course, a very important point. The traditional target that we've talked about is a composite of both patient-reported outcomes or improved symptoms with endoscopy or healing of the bowel. But now we know that there are many other targets that seem reasonable and can be selected individually based on the patient. These might include inflammatory markers like CRP or fecal calprotectin, extraintestinal manifestations may be your target, and of course in children and adolescents, growth and development may be the target. There is interest in radiologic imaging as a target, although not completely validated, but of course that offers an additional way to assess the disease. The main point here is whether the patient has lower risk disease or higher risk disease in terms of their complications and outcomes. You can stratify how rigidly and how importantly it is to achieve these targets and to monitor more carefully. The general principle in IBD that we've been advocating has been to use organ selective therapies before systemic treatments. That means topical rectal therapy before you use more systemic therapy for distal and frankly for more extensive colitis, but budesonide before systemic corticosteroids, Eustachia before systemically active and more systemically effective immunosuppressants, maybe in older patients or patients who have the paradoxical IBD after organ transplantation, but also thinking about which organ is involved, remembering that joints and skin may help you choose which therapy you're going to use and when systemic treatment is going to be better than organ selective therapy. Now, focusing more on the specific question of our biological therapies, remember now we have 3 classes of biologics that are available for IBD: the anti-TNF agents, anti-integrant therapies, which includes Natalizumab and Vedolizumab, although most are not using Nata anymore, and of course, more recently, Eustachia, which is technically an anti-P40 targeting the IL-12 and IL-23 cytokines. Keep in mind as well that although we know the most about anti-TNF, some of the general principles of pharmacokinetics of monoclonal antibodies apply to all of them. And this includes understanding that if a patient has anti-drug antibodies, they're going to clear the drug more rapidly. If they have a high BMI, they're going to end up with clearance more rapidly. Men seem to clear more than women. And low albumin is a predictor as well of a patient who's likely leaking protein or very sick and is going to clear the antibody more rapidly. Decreased exposure of the antibodies is associated with less effectiveness and therefore can predict or at least help you understand why a patient may be at high risk for primary non-response or secondary non-response with loss of response. Focusing on the anti-TNF therapies, of course, we understand the most about these therapies. There are 4 different treatments approved in the United States, 2 for Crohn's and 2 for UC. I'm sorry, 3 for Crohn's and 3 for UC. And we certainly have learned the most about how to position these. In ulcerative colitis and Crohn's, anti-TNF therapies have been shown to be steroid sparing, and they have also demonstrated preferred outcomes and high quality of life. We've also learned that combination therapy seems to be better at achieving our endpoints. Although we can sometimes withdraw an immunomodulator, the data of comparative effectiveness support using combo therapy. We've also learned a few other things. The biosimilars that are available and approved in the US, there are approved biosimilars for adalimumab and infliximab, but only available biosimilars to infliximab, and switching seems safe and effective. Many patients seem to need higher doses of these drugs. The safety is well described and should be well known to this audience, including reactivation of TB, chronic Hep B reactivation, or fungal infections. And as far as cancer, there's the possibility of melanoma increased with anti-TNF, but not solid tumors. And the lymphoma risk appears rare, but probably is real based on a French study, although the pediatric analysis suggests that it doesn't occur when you use TNF as a monotherapy, and it's primarily driven by thiopurines. We've learned that when you use anti-TNF therapies earlier, you get better results. This is an administrative claims study we did a number of years ago that showed that the patients newly diagnosed with Crohn's who went to TNF early, and without even knowing how severe their disease is, but assuming they must have had more severe disease to go to TNF inhibition early, were less likely to lose response, were less likely to need continuous steroids, and very importantly, were less likely to have Crohn's-related surgeries. So earlier use certainly has better outcomes. We've also learned that when you use anti-TNF earlier, it actually reduces the costs of care, whether it's related to direct costs or as you start looking at indirect costs related to loss of income from being able to go to work or inability to go to school and other things that happen to people who are sick. Having early therapy is also associated with cost savings. And this is a very important study that's been done looking at that specifically. We've learned a bit more about how to predict who's going to respond and who's not going to respond. This is actually post hoc analysis from the Act 1 and Act 2 trials that demonstrated that the patients who had the highest trough level of infliximab or infliximab level at week 8 predicted the likelihood the patient would be responding at weeks 30 and 54. So in your higher risk patients, when you think about all those predictors of rapid clearance, you can imagine using an earlier level of the drug to predict the need for dose escalation, try to keep the patients on track. And this is now becoming more standard, especially for those high risk patients. Now, having said that, it's not always true that you can just increase dosing and end up with better results. On the right is a summary of a meta-analysis that looked at accelerated dosing of infliximab in hospitalized patients with severe UC. And unfortunately, although the numbers are small, the meta-analysis demonstrates that overall it did not prevent colectomy. So in other words, giving more infliximab on day 3 or on day 7 did not seem to get more people in remission and certainly did not prevent them from ultimately having a colectomy. The second bullet point is the SERENE study with high-dose adalimumab, both in Crohn's and here mentioned is UC, at least looking at induction of remission, using 160 milligrams weekly for 4 weeks was not better than standard dosing of 160 milligrams at week 0 and then 80 at week 2. And therefore, it's very important to keep in mind that just giving more drug isn't always the answer. So knowing that there are other options is very important. The anti-integrant therapies, natalizumab and vedolizumab, remember, prevent leukocyte trafficking from blood vessels into the gut epithelium and therefore work by a cellular mechanism. Natalizumab, you'll recall, also works in MS and is less selective than vedolizumab. Vedo is selective only to the MADCAM system in the gut, and therefore it is thought to be safer. The anti-integrins available in IBD, vedolizumab is appropriate for both Crohn's and UC, very safe. There has not been any PML reported with vedolizumab, or at least not attributed to the vedolizumab, and it may not be the best option if you have extraintestinal manifestations. We've learned that concomitant immunomodulators are not needed for most patients. This has low immunogenicity, and of course, adding other drugs to this drug will reduce the safety of the therapy as well. We also know, just like anti-TNF, that dose escalation is needed for some patients. Remember that Vedo works well in UC and in Crohn's, and I think often we don't think of it or use it as often in Crohn's as we might otherwise. There's also been some nice work done now looking at calcineurin inhibitors for induction and Vedo for maintenance as a bridge strategy for patients who are sicker. Most recently is now what many will consider a landmark head-to-head biological study looking at adalimumab compared to vedolizumab. You can see the results of the Varsity Trial here. These were patients who had moderate to severely active UC, standard dosing of both ADA and vedo with a primary endpoint of clinical remission at week 52. You'll note that vedolizumab was more likely to achieve that endpoint statistically than adalimumab patients. You'll also note that even when you adjusted for prior TNF exposure, which was allowed in this study, it didn't make much of a difference. There are a couple limits to interpreting Varsity, however, and unfortunately, I haven't seen this change the way payers cover our therapies. The first was that it didn't allow dose escalation, which I've already mentioned to you is necessary. The second is that there were not reported out, and I don't think we have them yet, the drug levels, so we don't actually know that part of the story. And lastly, there wasn't a forced steroid taper. If you adjust for ongoing steroid use or concomitant immunomodulators, there actually was not a significant difference between the groups when you did that analysis. So there are some caveats to this. Nonetheless, I think this was quite an important study, and there are many more head-to-head trials on the way that I think will provide some insight for us. There are also developing some clinical practice tools or decision and analytic tools, like this one by our colleague Parambir Dulai, that uses some common variables to predict the likelihood of response here to vedolizumab in Crohn's disease. You can see a scoring system that includes prior surgery, prior anti-TNF exposure, prior fistulizing disease, and albumin, as well as baseline CRP, that predicts the low or high probability of response to vedo. So in the absence of knowing which drug you might use, you can consider this approach as a way to think about this is a patient who's likely to respond. Now, one thing to keep in mind is that a similar scoring system might be used for any treatment in IBD when you think about prior surgeries, fistulas, high inflammatory markers, etc. So certainly we need more work in this area, but I think this is a helpful tool to know a bit more about, and I would refer you to the full pub in gastroenterology. One of the questions that's come up is whether or not joint pain may be a contraindication for vedo or even Eustachia, recognizing that Eustachia and IL-23 inhibition doesn't seem to have a direct effect on the joints. Well, it may be true that joint pain would be a contraindication for vedo or Eusta. It may also not be true if the joint pain is specifically directly related to bowel inflammation. By fixing the inflammation of the bowel, you might in fact actually correct the joint problem. And if the joint pain is from steroid withdrawal, of course, that has nothing to do with whether the treatment you're using is causing the joint pain. You just have to manage the patient until that steroid withdrawal symptom goes away. There was a post hoc analysis from the Gemini 1 and a Gemini series of studies looking at whether or not patients who received vedolizumab developed new arthralgias or arthritis. And what you can see in these different graphs here from this paper is that when you looked at all of this, in fact, the patients receiving vedo had an overall reduction in their joint reported problems compared to placebo, and they did not have an increased risk of new onset joint pain. This may be different than what you've experienced in your own practice or anecdotally, but at least from the clinical trial data, and with the limits of knowing that we don't always capture extraintestinal manifestations in great detail, it suggests that this may not be as prevalent as people have suggested. Nonetheless, when I have a patient with inflammatory joint pain, I certainly think about other therapies before I think about vedolizumab. Now, there are some additional anti-integrants coming. Atrolisiumab is an anti-beta 7, so it does work on the alpha 4, but also on alpha E, and is proposed to have two mechanisms, both prevention of lymphocyte migration, just like vedolizumab, but possibly promotion of lymphocyte egress. So it prevents cells from going in, and it might actually push cells out or shut down that part of the inflammatory process. There are data for Atrolisiumab in phase 2 that look quite good in both ulcerative colitis. Here's the PROs and the endoscopy, as well as clinical remission results, as well as in Crohn's disease. And this therapy is certainly moving forward in both ulcerative colitis and Crohn's disease and looks quite promising. It also has demonstrated improvement in histological indices, as well as other markers of disease control, which makes good sense. And lastly, let's talk about Eustachia. Remember, I told you that this is an anti-P40 therapy, and P40 is a protein shared by IL-12 and IL-23. I usually describe this to folks as you're hitting two birds with one stone. You're inhibiting P40 and you knock out two cytokines. It has a single IV dose for loading, and then maintenance dosing is sub-Q every 8 weeks. It is also a very safe therapy with a low incidence of anti-drug antibodies. And similar to all of our therapies, dose escalation is definitely needed in some patients. Eustachia has been shown to be effective in Crohn's, and more recently in the UNIFY studies, and the most recent approval we've received for it has been in ulcerative colitis. And you can see here the results, both looking at the single IV dose for induction on the left, as well as the results of the maintenance trial on the right with remission, clinical response, and endoscopic healing. And you can appreciate why the every 8-week dose was selected for the maintenance. In psoriasis, which is also an indication for this drug, it's used at a lower dose every 12 weeks. At the University of Chicago, we have in press our experience looking at over 500 patients, and about 20% of them needed dose escalation with Eustachia. What we found in general is that if the patients responded initially to the IV loading, but weren't in complete remission or lost response later, our dose escalation actually worked in about half of our patients or even more. So the usual way to do this is dose interval shortening. And yes, it does require discussions with insurance. But now that this paper is in press, we've used our own paper, and I would encourage you to use this one and others to back up the request to get your patients more drug. As with all of our drugs, when we do dose escalation, we do it 2 or 3 times only. And if the patient isn't on track after that, it's time to move on to something else. There are anti-P19 therapies that will only inhibit IL-23 that are in development. This is Risekisumab for moderate to severe UC, and you can appreciate the results here, certainly better than placebo. And we've also learned about a potential biomarker with Risekisumab. Serum IL-22 levels are predictive of response to Risekisumab. So if you have high IL-22, you're more likely to respond to inhibition of IL-23. So wouldn't it be wonderful if this would be validated and we could then use this to predict likelihood of response to the IL-23 inhibition? Another IL-23 P19 inhibitor is Risekisumab, which has been studied also in UC and Crohn's. And you can appreciate here the results with Risekisumab at dose ranging. And this is expected to be coming to market for our IBD population. It's already available for psoriasis. And lastly, another P19, Risekisumab, for both UC and Crohn's, summarized here. Now, of great interest is that in the studies in psoriasis, they've also included studies of head-to-head between Risekisumab and Eustachia, which is demonstrated consistently that Riza is better than Eustachia. You can appreciate as well that Risekisumab studied versus Adalimumab, for psoriasis at least, was more effective for the therapy and provided more stability and a favorable safety profile. So head-to-head trials in psoriasis demonstrated at least that P19 inhibition, IL-23 selectivity, was superior to both IL-12, IL-23, and to anti-TNF with adalimumab. So this is a promising therapy, and I think we're going to be very interested to know whether it works better than Eustachia. Lastly, I'll just touch on optimizing your therapy. Remember what I've already said, combining your anti-TNF with immunomodulators. Also remember there are randomized trials demonstrating that if you have perianal disease and you're using anti-TNFs, using antibiotics at least for the loading phase, but even longer, improves the control of the perianal disease. And what I've called judicious use of proactive therapeutic drug monitoring. I gave you the hint of that for UC, but in your high-risk patients, certainly checking a post-loading drug level to understand who may be losing response over time. And now we actually have a proactive monitoring prospective trial in pediatrics that was positive with adalimumab. In other words, adjusting the dose of the drug based on drug levels had better outcomes. And lastly, don't forget, we're not just adjusting drugs for drug levels. You have to be looking at the disease activity when you make some of these decisions. I mentioned earlier that your first drug is likely to work the best. In most of the trials, that means looking at TNF naive versus patients who had been exposed and failed anti-TNF. And you can see whether you're looking at Veto with Crohn's or UC, Eustachia in Crohn's, and I could add UC to this, or even TOFA in UC, TNF naive patients seem to do better than those who've already failed. Now, whether this is a biological phenomenon or just an artifact of clinical trials and sicker patients who've already failed other therapies is not fully known, but nonetheless, remember that choosing your first therapy wisely has a good predictor of a response and is very important. In addition, as we talk about treat to target, you can use calprotectin to know whether a patient is responding. In the first 2 weeks of patients who ultimately responded to Veto or to Eustachia, you can see the calpro dropped precipitously. So in my practice, when I start a new therapy, any therapy for that matter, but you can appreciate these data, I usually check a calprotectin and or a CRP as early as 4 weeks, usually 6 weeks after I start treatment to make sure we're on the right track. And I think this is a wise thing to do. So not just post-loading drug levels in some patients, at least with anti-TNF, but checking on the disease response in all your patients when you start new therapies. I'm going to move on to the last point of this presentation, which is to think about which treatments would you choose as your first therapy. If you have a patient with perianal Crohn's disease, anti-TNF is still thought to be your best studied and on-label option with infliximab, but any of the anti-TNFs seem reasonable. A patient with coexisting psoriasis, whether it's drug-induced from TNF or a coexisting problem with psoriasis, Eustachia seems reasonable and appropriate. Your older patients where there's a higher risk of opportunistic infections, Veto and Eustachia are safe and seem like good options in that scenario, but that doesn't mean you can't use other treatments when you really need them. If your patient has an inflammatory arthritis or synovitis, using anti-TNF, or if they have UC, tofacitinib, just remember TOFA, as you'll hear in discussions at this meeting, is positioned after the TNF. And lastly, remember what I said about low albumin, which usually means leakage of protein. A small molecule induction strategy might be a reasonable thing to do in that scenario. When you get to your biological therapies, you can stop 5-ASA if you've escalated through them. There are now 2 different studies that demonstrate the safety of doing so and the lack of ongoing efficacy of doing so. Recognizing that in both of these analyses, patients escalated through the 5-ASA, I think that it's reasonable to say that in your own practice when that happens, withdrawing the 5-ASA is perfectly reasonable. And lastly, when you have a patient who's losing response, just remember the basic principles. Confirm adherence to their therapy, rule out infection, make sure they're actually inflamed, know where your drug is. Are they clearing too much? Are you underdosing them? And if they have anti-drug antibodies, make sure that you protect your patient from getting them on their next treatment. This is especially true in anti-TNF therapies, which has been shown in several important studies now. When you do make a switch because a patient loses response, you can likewise use some of these other co-modifiers or coexisting diseases. An anti-TNF induced leukoid reaction, any treatment outside of the TNF class will be a reasonable option, and the leukoid reaction should resolve over time. The patient with joint pain on Veto, if it's not steroid withdrawal, consider some other therapies that may have more directed joint targeting and involvement, like anti-TNF or TOFA. If a patient has anti-TNF-induced psoriasis or the palmar-plantar pustulosis, basically anything that's not TNF is reasonable. There's been more studied and described using Eustachia in that scenario, but there are some case reports with Atrolisiumab here, as well as some now with tofacitinib. And lastly, if a patient has a solid tumor and they're receiving cytotoxic chemotherapy, you might do no immune suppressive treatment while they're getting their chemo. But if they need other therapies, it's reasonable to try one of our safer options first. Although again, once a patient's had a solid tumor and they're in remission phase, or even if the tumor is still occurring, anti-TNF appears safe based on many studies that have tried to look at this question. So I know I've covered quite a bit. I hope that I've given you some insight into thinking about both our anti-cytokine therapies with anti-TNF and anti-IL-12 and 23. I've given you a little insight into some of the future anti-P19 therapies that are coming, as well as the anti-cellular therapies with anti-integrants, both the available vedolizumab as well as an emerging therapy, Atrolisiumab. Remember that combo therapy makes sense for some scenarios, especially with anti-TNF and especially in the setting of perianal disease. Optimize your treatment, which includes not just the drug, but also assessing the disease. And lastly, make sure that you're thinking about comorbid illnesses and other reasons to choose a second therapy and understand why it might be needed. Thank you very much for your attention.